Hello, dear IPHA members. So, on behalf of Indian Public Health Association, we present a special lecture and panel discussion on the occasion of the World AMR Awareness Week 2024. So, dear colleagues, as we know that antimicrobial medicines have saved millions of lives over a century, but now drug resistance is threatening, and we are in a situation where the effectiveness to treat disease is at risk. So under such situation, I think the awareness regarding this antimicrobial resistance, understanding it and taking action would be the most important thing. And IPHA being a premier institute working on the field of public health would definitely pitch in for this special discussion. So on this program, World AMR Awareness Week 2024, we have a program on a comprehensive One Health approach for AMR in India. And to begin this, I would request our President IPHA, Dr. Sanghamitra Ghosh, and Dr. Kaushik Mitra, Secretary General, to give their welcome address. So I would request Dr. Sanghamitra Ghosh, our President of the Association, to give her address.
Thank you, Pritam. Good evening, everybody. Welcome to the special program on antimicrobial resistant effectiveness of life-saving medicines and the management of infectious disaster worldwide. This year, we mark World AMR Awareness Week with theme Educate, Advocate, Act Now. As President IPHA, the urgency of addressing AMR is clear. India being a big density populated with restricted healthcare access and the misuse of antimicrobials amplify the rise and impacts of AMR. We also have indiscriminate use of antimicrobials in poultry and animal sector. This is introducing the problem in food chain. Today, we need to discuss and take decisive action to combat AMR. It is only through united efforts and commitment that we can protect the efficacy of AMR for prevention. The choice we make today will impact the health of future generations. Our commitment is key to transform actionable plans into outcomes and impact. So I welcome all of you, all the participants, all the speakers, and our dear editor and managing editor Dr. Rajiv Dashgupta as moderator, and Dr. Pritam Roy, managing editor, as another moderator in this program. I wish all the best. Thank you.
Thank you, ma'am. And as the president leads the association, I think it's a very nice way that we got introduced to our session today. Thank you so much, ma'am. And I would also request our Secretary General IPHA, Dr. Kaushik Mitra, to also share his thoughts in the welcome address. Over to
you. Thank you, Pritam. And good evening, everyone. So today we have gathered here for a webinar on antimicrobial resistance. So antimicrobial resistance is actually a silent pandemic. It's directly linked to the development and use of antimicrobials that have been used in the human, animal husbandry, and agricultural sectors. So its impact is manifested in terms of increased healthcare costs, long-lasting disabilities, threat to food security, and severe effects on livelihood, loss of human and animal lives. So to combat this antimicrobial resistance, we have resorted to One Health approach. The One Health approach is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and environment or ecosystems. And IPHA, that is Indian Public Health Association, is committed to it. We acknowledge that the invisible pandemic of antimicrobial resistance is a global and national public health priority that needs our urgent and focused attention. We reaffirm that National Action Plan on AMR and different state action plans on AMR, with their 6 strategic priorities that we know, provide the roadmap for containment of AMR in India. So IPHA is committed to advocate and collaborate to prevent and contain AMR in India by supporting the implementation of national and state action plans, educate and support medical professionals to prevent infections, promote research and optimize the use of antimicrobials, and to support initiatives to raise AMR awareness and behavior change amongst the patients and the public. And Indian Public Health Association, IPHA, is a signatory of National Alliance of Medical Professionals Against Antimicrobial Resistance. And we are always committed to it. So, thank you. Long live IPHA. Over to Dr. Pritam Roy.
Thank you, sir. I think the way you emphasized the IPHA's contribution and the future plan of how IPHA can support this comprehensive One Health approach for AMR, I think that is really helpful, and this will lead to the more discussion. And I think overall, all the members, we will be working together for supporting this. So after this, we will be having a special address by Dr. Anuj Sharma, who is the focal point for AMR and IPC team from WHO India. And then we'll have a panel discussion moderated by Dr. Rajiv Dasgupta with a concluding comments from our dearest ma'am, Dr. Sunila Garg ma'am, who is the chairperson of the academy. So before we go for the special address, I would request all of you to focus on the camera screen so that we can take a group photograph, and we'll try to make a go blue and we'll try to put it in the website. So requesting all of you to have a look on the camera screen so that we can have a picture. Yeah, thank you all. So I would now request Professor Rajiv Dasgupta to take over the session from me, and would request our guest to have the discussion ongoing. Thank you.
Thank you very much, and welcome Professor Sunila Garg also. Good evening. Okay, and absolute pleasure and privilege to have the resource persons, both for the special address as well as the panel. So I join Dr. Pritam Roy in welcoming Dr. Anuj Sharma, Focal Point AMR and IPC Team WHO India. To introduce Dr. Sharma, he is a medical microbiologist by training and has served in different positions in the WHO for the last 10 years. He has been central to the formulations of India's National Action Plan on AMR, as well as the state action plans. He facilitated recently the forming of the National Alliance of Medical Professionals on AMR under the aegis of the Indian Medical Association in July 2024, and IPH is privileged to be part of this alliance. Over to Dr. Anuj Sharma for your special address. Yeah, it's visible.
Dr. Anuj, I guess you are on mute. Can you please unmute yourself? We can't hear you.
My apologies. I think I started. So a big thank you to IPHA for prioritizing AMR and inviting me for this address. So I will be speaking about AMR containment in India, primarily from the WHO perspective. But just to remind everyone, the World Health Organization is the UN lead technical agency for health, and our highest governing body is the health ministers from the 194 member states that we have. And it's a tiered organization with headquarters in Geneva, 6 regional offices, and more than 150 country offices. And we are mandated to work with the ministries of health. So we work very closely with the national AMR programs, and at the country office, we work closely with the Ministry of Health and the other stakeholders, primarily supporting the national AMR program. And a lot of activities are actually being done, but I'll give you a glimpse of some of the things. So I'll talk about AMR containment in India, the National Action Plan, the various initiatives as per the strategic priorities, the need for state action plans, and I'll end by a slide on the World AMR Awareness Week. Now, all of you are aware, India's journey towards AMR containment started in 2011. And when the National AMR Task Force was set up, followed by a national policy on AMR containment in 2012, which paved the way for the National AMR program under the 12th five-year plan started by NCDC. But at the same time, ICMR also started their AMR program. And there's been a lot of activities, and I'll give you a glimpse of some of them, and not all of them. Of course, there are national standard treatment guidelines. But in 2016, after the Global Action Plan was endorsed at the World Health Assembly, the health minister was very keen that India should also develop its national action plan. And to facilitate that, we partnered with NCDC and ICMR and the Ministry of Health to develop this background document on AMR and its containment in India, and also helped in the drafting of the strategic framework for developing the NAP-AMR, the 3 governance mechanisms, Intersectoral Coordination Committee, Technical Advisory Committee, and the co-working group. And after nearly 8 or 9 months of work, the National Action Plan on AMR, which was developed over a period of focused group discussions, followed by a national workshop and a national consultation. This was launched at the Interministerial Consultation on AMR, along with the Delhi Declaration on AMR. And the point here is that this was signed by 4 union ministers, 2 from health, 1 from food, and 1 from the environment, signifying the One Health approach for AMR. Now, again, 2 more ministers were supposed to join who could not sort of come at the last minute. But again, there was commitment from those 2 ministries which could not attend at that point in time. Now, the 6 strategic priorities of India's National Action Plan on AMR are aligned with the Global Action Plan on AMR. The 6th strategic priority on governance, coordination, and collaborations is specific to India's National Action Plan. And I will go through these 6 strategic priorities and the focus areas. And again, if you look at the 16 focus areas, the focus areas with a white background signify that the action has to happen across all sectors. If it's only blue, then it's in human health. Yellow is for food and the animal sector, and green is for the environment. So the majority of these focus areas they cut across all sectors, since AMR is a One Health issue. So I will take you through a majority of the human health issues. So World AMR Awareness Week is an opportunity to spread AMR awareness through resources, through various mechanisms to raise public awareness. The Go Blue is another sort of event which looks at developing global solidarity for this public health threat, and again using social media to spread the messages of AMR, especially why people are going blue, because how it's impacting not just human health, but all the other sectors as well. Also, as an organization, we've gone blue last year. There was an interview by WR which had a lot of views, and also we had group photographs of the office as well as the office collage. Also, we had teams across India which had shared their photographs going blue, wearing blue, and also using social media to raise public awareness about AMR. At the India office, we also, in terms of knowledge management, we bring out these two compilations. This started during the pandemic, the Samiksha on IPC for COVID-19, but after the pandemic was over, this has been broadened for all aspects of infection prevention and control. And in 2021, we also started the Samiksha on AMR, which actually both of these are compilations on AMR and IPC, which is summarized in 2 bullet points along with a link to the full text resource. Coming over to the second strategic priority, labs and AMR surveillance, India has a number of networks. There's the National Antimicrobial Resistance Surveillance Network coordinated by NCDC, as well as the National Antimicrobial Consumption Network coordinated by NCDC. Plus, you also have ICMR's AMRSN, the Antimicrobial Research and Surveillance Network, and also the AIIMS Trauma Center, which coordinates the healthcare-associated infection in collaboration with ICMR as well as NCDC. And in the animal health, you have the ICAR coordinated Indian Network for Fishery and Animal Antimicrobial Resistance. But in addition to these, the TB program also has a strong focus. The HIV program also has a focus on drug-resistant HIV. The STI program has enrolled in enhanced GASP program, which is the gonococcal antimicrobial susceptibility program, to strengthen the evidence on AMR in gonococcal infections. There's AMR surveillance happening within the leprosy program, as well as surveillance on drug-resistant malaria as well. Also, to increase the scope of the AMR surveillance and also to push AMR agenda in states, we collaborated with state governments and NCDC and the state medical colleges to establish the state AMR surveillance network, starting with Maharashtra, Mahasar network in Maharashtra, CARSNet in Kerala, and DENSAR in Delhi. Also, these reports are available on the NCDC and the ICMR website, and some of the state AMR surveillance networks are not available online, but these are available with the state government, and the DENSAR actually published their report online. ICMR also has a national essential diagnostics list in which the district hospitals should have culture sensitivity facility to enable the detection of AMR at the district hospital level. Third strategic priority is infection prevention and control. And of course, there is the national quality assurance standards for public health facilities, urban public health centers, looking at quality systems to be in place in Indian healthcare facilities. Of course, the Swachh Bharat mission by the Ministry of Jal Shakti is also strongly focused on sanitation and hygiene, which prevent infections. The Kayakalp program, Lakshya program, looking at the labor room quality improvement initiative, and of course, the Ayushman Bharat through the health and wellness centers are also aligned with providing safe care, quality care, which can also prevent infections, promotive care, which can prevent infections. Also, at the national level, we partnered with the Ministry of Health also to develop the National Patient Safety and Implementation Framework, within which AMR is one of the key priorities, just like the National Action Plan on AMR. Also, NCDC and the Ministry of Health developed the national guidelines for infection prevention and control in healthcare facilities, on the basis of which a national level training of trainers have been done for all states, and these have actually been rolled out in a couple of states as well. Also, there's the national IPC curriculum, which is under development. And of course, the national HAI surveillance network is in place. And of course, this is also prioritized under the state action plans for containment of AMR. And some of the states have already prioritized and are working on IPC in a program mode. Fourth strategic priority, optimizing antimicrobial use. Both ICMR and NCDC have surveillance networks which look at monitoring antimicrobial consumption and use across India through Sentinel surveillance. And of course, their reports are also available on their website. Also for antimicrobial stewardship, both NCDC and ICMR have their treatment guidelines for empiric use of antimicrobials, and ICMR also has their antimicrobial stewardship guidelines, which are also available as an application, a smartphone application as well. NCDC is developing the National Antimicrobial Stewardship Guidelines, and also there's a national guidance on antimicrobial use in orodental infections developed by the Department of Dental Research at AIIMS, and this has been submitted to the ministry to endorse as the national guidelines, because 10% of antibiotics used in human health are used in the dental sector. Also for research, there's a lot of activities happening by ICMR, Department of Biotechnology. We've conducted research on environmental AMR transmission, also disposal of medicines, and multicentric study on MDR infections. Also, the Indian priority pathogen list was developed in partnership with the Department of Biotechnology. Also, the Office of the Principal Scientific Advisor to the Government of India chairs the India AMR Innovation Hub, which has CCAMP, the Center for Cellular and Molecular Platforms, as the secretariat, and a large number of government ministries, departments, and a number of development partners, including WHO, are part of the advisory council for this. And there's a lot of focus on promoting research and innovations for AMR containment. Collaborations are critical to move the agenda forward, and we are working with a number of civil society organizations to push the AMR agenda. Also, collaborations with professional associations across the various disciplines, pediatrics, microbiologists, infection preventionists, and of course, Indian Public Health Association, Indian Society of Dental Research, and Indian Medical Association, and also the National Neonatology Forum, the Medical Students Association of India, and of course, with IMA forming the, we supported IMA as the co-convener for the National Alliance for Medical Professionals on AMR. Also within WHO, we have a number of teams with whom we work on various aspects of AMR, with the TB team, the STI team, leprosy, health systems team, the National Public Health Surveillance Network, the Health Security and Emergencies, the Reproductive and Maternal and Child Health team, Environment team, and of course, we also host the Health Partners Forum. But all teams work together for the World Health Day in 2011. There's a task force in place, and we use and leverage our AMR workforce across the country to advocate for AMR, not just during the World AMR Awareness Week, but also other events. But there are a large number of stakeholders in India for AMR containment, not just the 4 key ministries, but also Niti Aayog, a principal scientific advisor to the Government of India, and a large number of organizations across sectors, and a number of ministries which need to work together with a One Health approach. And more importantly, it's also the need to develop state action plans, because all the sectors important for AMR containment have state government responsibility: human health, animal health, fisheries, agriculture, environment, and of course, food as well. And the journey for state action plans began in 2018 with the SAPCAR guidance, with the template to develop state action plans. But Kerala's action plan was already developed by that time. And subsequently, a number of states have developed their state action plans, and the National Action Plan 2.0 is also in the pipeline and is expected to be launched soon. But just my last slide, and a request to all of you to use this opportunity, the World AMR Awareness Week, to spread awareness about AMR. And the theme this year is Educate, Advocate, Act Now. A large number of WHO events are being organized and the program is available on the WHO headquarter website. We've organized a number of internal meetings and workshops for our technical staff across the country. We are also planning a social media campaign, and the National Newborn Week, coordinated by the Child Health Division and the National Neonatologist Forum, has identified AMR as the theme for this week, and also the World Toilet Day, 19 November. The Ministry of Jal Shakti is also sort of pushing this as a key theme. AMR is a key theme in a 2-week-long program, on having safe and good quality toilets across the country. So again, a request, 24th November is the Go Blue Day. Request all of you to work together for AMR containment. And again, the theme, prevent AMR, this lapel pin sort of signifies that we have a number of stakeholders that need to work together, join hands for AMR containment, not just across sectors, but also within sectors. So I'll stop here. Back to you, Dr. Rajiv.
Dr. Sharma, thank you very much, as always, for giving this overview, both of national priorities as well as the progress in the states. So thank you very much, Dr. Anuj Sharma, for the special address. We now move to the panel discussion with you setting the context. First, I'll introduce the panelists. We have the privilege of a wonderful panel. I'll introduce in the alphabetical order of the first names. So we have Dr. Mahua Das. She is lecturer international health at the University of Leeds, UK, where she also serves as the program director for the MSc in International Health program. She specializes in health systems and policies and disease prevention and control using community engagement approaches in LMIC contexts. In South Asia, she has worked in Nepal, Bangladesh, and India, and is involved in several interdisciplinary research projects, primarily a qualitative researcher, researching both in community engagement as well as policy research. Our second panelist, Dr. Pallavi Mishra, is a postdoctoral fellow at the Jawaharlal Nehru University, part of the UK RIGCRF One Health Poultry Hub for the last 5 years. And her research has been around people, poultry, One Health, and AMR. She's a trained qualitative researcher and primarily engaged in policy research. Dr. Robin Paul, our third panelist, is the technical officer, AMR and labs with the FAO, India. He's a public health veterinarian with expertise in laboratories, surveillance, One Health systems, antimicrobial resistance. He led the drafting of the One Health AMR action plan of Kerala that Dr. Anuj Sharma spoke of, and operationalization of agricultural dimensions of state action plans of 3 states of India. He is a key figure in sensitizing the broader veterinary community about prioritizing food safety and AMR, for which he's been trained at the National Veterinary School of Nantes in France and the Federal Agency for Safety of Food and Feed in Belgium. Our fourth panelist, Dr. Sagar Khadanga, internal medicine specialist at the All India Institute of Medical Sciences, Bhopal. With interest and expertise in infectious diseases, he's been an observer in infectious diseases at Wayne State University, Michigan, and he's recently completed his fellowship in general infectious diseases from Christian Medical College, Vellore. Most importantly for us, he is the nodal officer, technical committee of the Madhya Pradesh State Action Plan on AMR, widely published in peer-reviewed national and international journals. And Dr. Sandeep Ghatak, our fifth panelist, he is head DAFS principal scientist, is a veterinary public health specialist and heads the division of animals and fisheries sciences, ICI research complex for the Northeast region. Dr. Ghatak's research interest focuses on genomic epidemiological studies of antimicrobial resistance in bacteria. Following the One Health approach, he and his colleagues from diverse backgrounds gather and analyze data and evidence that help explain the transmission dynamics of the drug resistance at the interface of humans, animals, and environment. To understand and visualize the bacterial genomics data, he often resorts to bioinformatic tools that complement the wet lab data for better communication to a broader audience. And Dr. Ghatak has a special interest in science communication. So once again, a very distinguished panel, welcome, and thanks to you on behalf of the Indian Public Health Associations. We are absolutely dot on time. So we will be rotating the questions across the thematic areas. Given that we have 5 panelists, we have diverse expertise, I would request to keep your answers as short as possible. And I would apologize in advance if I need to move to another panelist to strengthen the discussion. Let me start with Dr. Sagar Khadanga. Over the last few days, this week, the AMR Awareness Week, the Down to Earth digital edition has published a series of articles. And of the 6 panelists here, 3 are authors in that series. So your article coming from an internal medicine specialist, the title is "Lack of Community Engagement is a Major Shortcoming of the AMR Business Model," which is an interesting term. And in specific, what I would like to start with, you write that it's an unfortunate paradox that AMR momentum is least advocated where antibiotic usage is most, because of limited financial resources, inadequate infrastructure, and insufficient monitoring. And you, towards the end, you suggest that the AMR advocacy is well presented and well accepted among the educated urban areas, but of course has to travel a long distance among consumers in rural India. First, thank you very much for focusing on the community engagement. Do you really believe that it is an agenda in urban India, your experience?
I strongly believe it is an agenda in urban India. At least in the white collar people, the officers, or the so-called the administrators, it's an agenda for sure. Probably more so in the month of November, but it's an agenda around the year, at least among the elite healthcare, either animal or human healthcare. My issue is always, unless otherwise we create a demand in the community, that will not solve or it will fail. If the demand has been will arise from the community, then the supply will be there. Probably at this point of time, we supply more, but the demand is less. I would like to know from other panelists how the demand can be created from the community.
Thank you. And on that note, if I move to Dr. Mahua Das, who has been working for several years now on community engagement, particularly in the matter of AMR, how do you really see the challenges are, and in your experience, what could be the recipe for some progress? Maybe it's a little rash to call it success, but what is the recipe that you would suggest, assuming there is one?
Thank you, sir. I'm really glad to be a part of this very interesting discussion, which has come very timely. I mean, throughout the presentation that Dr. Sharma made, I was trying to figure out where is community engagement. You know, we are talking about various stakeholders. We are talking about all the ministries, all the state acting bodies. But where are the people who this entire problem is affecting? Is it, why isn't the community one of the stakeholders? And I think this has been a problem in the way any action towards antibiotic resistance has been addressed. I have worked for many years in Bangladesh, And in one of our pilot projects that we conducted in Bangladesh, we tried to adopt a community engagement approach called the community dialogues to see if that can be used as an approach to create awareness. Now, as you can imagine, one of the key challenges that we faced was we were talking about an invisible pandemic. You know, the problem of AMR, it's very difficult to talk to the community about it because they don't understand what this resistance is. What are these patterns of resistance we are talking about? What are these antibiotics for? Because for them, they hardly know the difference between any paracetamol versus any antibiotic that has been given to them. So one of those challenges, as I said, was to make people aware of this invisible, hidden pandemic that we are talking about, antibiotic resistance. And then the other challenge would be to understand what is it that the local, what does the context say about the nature of the problem? So until and unless we understand what are the community drivers of antibiotic resistance, it would be very difficult to come up with any comprehensive approach that we are talking about to address antibiotic resistance within the communities.
Thank you. And if I move to Dr. Pallavi Mishra, who you work in the international policy space. So if you look at the even General Assembly statement, it of course talks of reaffirming the primary role and responsibility of governments. And then it goes on to say that beyond the health sector, to act beyond the health sector in order to pursue whole of government, whole of society, and community-based approaches, as well as the consideration of health in all policies, equity-based and life course approaches. Is it too much of jargon, or is it doable in a reasonable time frame, particularly the SDG time frame? Dr. Mishra.
Thank you, sir, for this question. And I would say, like Dr. Mahua, as she was saying, reiterating the same, I think timelines are like really aspirational. And when we develop a document or when we set the desired goal, we often tend to be ambitious. There are certain goals which can be achieved, and there are certain goals which we are very positive that we'll be able to not, if within the time frame in like next a few years or a decade we will achieve. I see the problem, whether it's in the international context or at the more precisely at the national context. I would say that there is an upstream issue and there's a downstream issue, and especially if I talk about community engagement per se. So there is a solution which is drafted at the national or the international level. However, the local context is often ignored, and we can take the example of, for instance, WASH. So we come up with this plan of having toilets in each village and making the village ODF and other stuff. But however, we tend to often to ignore the availability of resources at the local level, whether water is available, whether soap is available. And same is the case with AMR stewardship program and several guidelines, for instance, washing hands at the community setup or at the health within the hospital. But we are often not looking at the availability of resources at the local level. So until and unless we do the situational analysis at the community level and not just see them as a beneficiary of some policy or plan, making them a equal partner in the process, I think it will take time. It may not happen in a decade or a few years, but if aspire to make them a part of decision making or policy making, I think that will also be a great success.
Thank you. And I'll take up your cue on upstream. And I would direct this discussion to Dr. Sandeep Ghatak. He's a laboratory scientist. So I'm referring to the Jeddah Declaration 48 hours ago. It says strengthen upstream scientific research to better understand the mechanisms of antimicrobial resistance and its impact on human, animal, and environmental health. My question to Dr. Ghatak, particularly for our audience, is where do you think India needs to focus its upstream research?
Well, thank you, Professor Dasgupta, for giving me this opportunity. I'm really honored to be part of this panel. Well, there are a couple of upstream research areas that we can specifically take it up. Well, the point may be that there is, if we refer back to the O'Neill Commission that we often cite, there has been a much impetus on that research has to be on various aspects, not only for the directly that are related to the AMR, one that are supplementary to it. In human health and the other sectors that where I understand we have a couple of public health experts who can deliberate better on this. Of course, we do need point of need rapid diagnostics that we still lack, and that is why perhaps the PS's AMR Innovation Hub has put a special focus on that, on rapid diagnostics on this. And with the current advancement in the microfluidics, there are a couple of new assays are coming up, but still bacteria being a biological entity, we cannot shorten the time to identify and give clinicians a result on which they can work upon. This is one area. Similar paradigm on the identification of the movement of the AMR bacterial clones, as well as the correlating them with antimicrobial usage. We do not have essentially in India much data on antimicrobial usage. We do have a network that focus on, but the vast India being such a vast country, we really have only piecemeal information on which to form a policy is really difficult. If we look into the other sector where the consumption of antimicrobial is quite high, that is agriculture, that means animal agriculture. In that sector, the situations of these two diagnostics are even poorer. Our animal health sector in India does not essentially have point of care diagnostics for the vast majority of the government supported system. Of course, our pet clinics are well ahead. They depend on various imported diagnostics, but they are mostly not used for making a decision on this. So we need to focus on the same objective here in the animal side, where to use it. And of course, identifying the movement from the animal sector to the human sector or the vice versa, that also need to be prioritized. Given all these, as Dr. Anuj Sharma was so aptly and so elegantly presenting, that there are so many databases are there. So many networks, so many identification networks are there who has all these data. And despite having all these data, you hardly will find a coherent, consolidated picture of the country or even for a state. We do not have it. Can we harness artificial intelligence in harnessing and summarizing these data? This is an area which needs to be explored. India, we all know, we claim and we know that it's a soft power hub in the computing and others. Why can't we do on these? Because so many databases, yet tomorrow you ask me that give me 5 points on these data, what is the picture? I browse so many websites. That's the reality for all of us who perhaps work here. So these are the couple of areas. I don't want to elongate, this one. Naturally, things will come in from the human side after the discussion for more. I believe these are the 3 areas where we need to focus on. And on the animal side, let me add one. In animal side, let us understand this is a commercial venture. This is not a health equivalent of the animal from the humans. It is a commercial one. It is all the antimicrobial usage, the research, all has to be tied to the ultimate economics. What does that mean? Do not expect that a farmer who is using unauthorized way antibiotics will be going for using a diagnostic kit to take a decision. We have to keep this reality in our mind while funding our research, because that will really give us a tempered view of where we go ahead, how we fund our research, where we take up our research.
Thank you. Dr. Robin Paul, a dear friend, and he's been waiting patiently. So to come to you, Dr. Paul, and to connect to the last thing that Dr. Ghatak said, and to connect back to the overall community engagement. So you are someone who has extensive experience both at the state level as well as at the national level. So as far as the veterinary sector goes, what are the current strategies to engage rural veterinary practitioners as well as livestock farmers in the transsectoral AMR efforts?
Thanks, Rajiv sir. I'm fully on page with what Sandeep says. Fully on the same page with what Sandeep says. Essentially, in India, the farming activities, it is a private sector activity, and unless we admit and understand that it's a private sector activity, and the government has very, very limited controls on all what is happening in the animal health sector. Yesterday, I was in Mangalore with the fishery sector. It's also the same way. It's the same system. It's almost the same system, because the production is driven by the private sector. Last week, we were with the National Dairy Development Board, where they do extensive amount of work. So unless the government deeply engages with the private sector, we will never be able to reach the communities. So probably the channel to engage with the communities is through the private enterprise. It goes like that. Probably even in the human case, 75% of our treatment happens in private hospitals. So unless you have them in all your programs, you will hardly be able to make any impact on the way. So that's what all I have to say on this.
So,
Is that unless we have the private sector in, we will never reach the communities, because these in the animal production side, they sell it to, if poultry, sell it to integrator. Same is the case with aqua, he will sell it to integrator. Milk, he will sell it to a dairy cooperative, who is also an integrator. Basically, so there is some place where it comes. So we know the channels on how to reach the community, and probably we should utilize some of these channels at least to begin with.
so let me connect you back. I mean, link this with commitment 7 of Jeddah resolution, which says encourage WOAH through consultation with its members, etc., such as the veterinary equivalent of the WHO AWARE framework to facilitate improved guidance, targeting, and measuring appropriate use of antibiotics in animals, a theme Dr. Ghatak also spoke of. So in terms of both veterinary public health systems as well as the veterinary, the livestock farmers, what do you see is the way forward? We know what the barriers are largely, but what's the way forward in a policy making position that you are?
Is it to me, sir?
Yeah, it's to you.
That's a tough question.
That's why it's for you.
That's a very tough question. You said where we are actually in policy making. Probably the first thing is we need to tighten up at least few of our laws to begin with, at least some of the laws. We have a very stringent food safety act, but that food safety fellow cannot enter any farms. So all antibiotics is used in farms. So his act is as good as it's a paper document, because he cannot enter any farms. Antibiotic is used in farms. So unless yes, procurement is one of the greatest drivers for behavior change, as Rajiv sir would agree, and probably the procurement people can influence the farmers. So that is one way forward. Otherwise, I don't find any way forward where the community can be influenced to make a behavior change. So probably if the procurement, even one thing, I was asking Anuj sir also, at least when you are in hospitals as a part of your stewardship program, why don't you say that you will give antibiotic free milk to your patients in the hospitals? So at least hospitals down the line, whenever you use animal products, you should at least focus on antibiotic free to your patients in who are in ICUs or wherever you serve the food. At least the message is taken down that there is a problem in this case. So procurement is one of the drivers which can drive behavior change. This is what I understand. To be short on this.
Thank you very much. To move to the policy space, and if I get back to Dr. Pallavi Mishra, what do you really see are the challenges in the implementation of AMR related policies?
So again, thank you for this question. So there are 4-5 major issues which I see that in the implementation of AMR issues and AMR policies, and at different levels the challenges are different, but in general I'll just give a broad overview of the challenges. And I feel that lack of this lack of funding and dedicated funding for AMR, that is one of the issues, because we have been speaking with the state level people at the state level who have state action plans there in the states, and they mentioned the biggest issue with them was that there's a lack of dedicated funding, and most of the funding comes from intergovernmental agencies. So that is certainly one of the issues. And the other issue is I would say there is also a lack of a trans-sectoral approach and overlapping jurisdiction, where different departments, for instance, uh, 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 different departments and ministries, they have overlapping jurisdictions. And for instance, for AMR, FSSAI has its set of rule, ICAR has its set of they have set of rules, and other departments also have their regulations on AMR, but due to lack of coordination and concerted efforts, I think there is also a gap in the enforcement of the AMR policies or the AMR regulation. And also there is lack of emphasis on mandatory reporting, whether it's private sector hospital or the district level hospital or the tertiary care hospital. I think that is also something that needs to be that needs to be emphasized. And lastly, I feel that in the state action plans and the national action plan, there is a lack of adequate monitoring and evaluation. It does not talk in detail about the monitoring and evaluation framework, which is required to assess the success of the plan and also for creating, an atmosphere of learning. So yeah, these are the few things that I would like to mention, sir.
Thank you. So continuing with this thread, and this question is to Dr. Sagar Khadanga. Dr. Sagar, you have been in the leadership position in Madhya Pradesh, a large and diverse state with a very, very challenging set of conditions. So what do you see? A very straightforward question. We are banking, as far as the human health goes, a lot on the antibiotic stewardship programs. So very straightforward questions. In your experience, what are the challenges that antibiotic stewardship programs face?
Ultimately, stewardship means something has to be done as per the protocol or something judicious, something ethical. For example, if I would like to give you a small message, my father says, don't tell a lie. It's up to me whether how I would take it. For a survivability at some point, I may tell a lie, but most of the time I should not. So ultimately, to me, antimicrobial stewardship practices, which can be differentiated into three broad pillars. One is diagnostic stewardship, the treatment or the clinician stewardship, and as a whole, the administrative stewardship, community stewardship, and all. I am more focused as a clinician on the clinical stewardship. For clinical stewardship, we require minimal knowledge. Within 2 to 3 hours, a short course, all MBBS doctors can be made aware about the syndromic approach of antibiotic usage. But somehow it is not taken in the curriculum for last 10-15 years. Who will tell the MBBS doctors that in upper respiratory tract infection, majority of the time it is due to viral, you need not take anything other than paracetamol or citrate. But even in COVID, if you look at various guidelines, can much azithromycin, thinking that there may be secondary. So if even the biggest policymakers will prescribe antibiotic for viral infection, so where do these MBBS students will, what is their position? So probably this is high time we make AMR as a curriculum in the MBBS veterinary. Rather than thinking about it, when they are exposed to the community, they should be taught right during their school days. Till now, 10-15 years, we are talking about AMR and there is no curriculum. So my priority will be at this point of time, let's teach them. 95% of the time they can use judicious antibiotic when if they are taught over a period of 4-5 hours. So I would like to take that as a challenge if we can implement that in our course curriculum for the students nursing and
Thank you. To come back to Dr. Mahua Das, you are a social scientist. You worked in diverse LMIC contexts, both in South Asia and Africa. How do you see AMR and given the SDG UHC lens, how do you see AMR actually exacerbating existing health inequalities? Why? I mean, how do we frame AMR as an equity issue?
That's a very interesting question, sir. Thank you. I mean, as we all know, AMR is quite an issue which is related to overuse as well as underuse. So I think until and unless the policy making, the regulation is really, strict and clear about what is overuse, what is underuse, and what is the judicious use, I think it's one of the challenges, and this might create more inequities in the communities that we are working with. One of the other inequities that we are thinking about is, when you're talking to a farmer and telling him that do not use this particular brand of feed because it has certain antibiotics in it that promote, growth. For example, I'm not a agriculture specialist, but as a layperson, so if a farmer is given this message, the farmer also knows that if the antibiotic is administered, that will lead to more crop growth, which means more harvest, more crops to sell, which will mean that they'll earn more. So why, for that farmer, would that be important, that he considers thinking about what a drug can do and how it can impact on the health of people who are buying products for them, and not think about how it would impact on his family income, on his on his livelihood. So I think that is a very ethical issue as well when we are talking about community being at the center of all these interventions we are talking about. We are talking about introducing diagnostic tests. Very interesting. I mean, I'm completely I'm totally impressed by this idea. But then if we are asking farmers, for example, to conduct these rapid diagnostic tests, would they know how to do it? would there be that awareness that, okay, this is probably the first symptom that I'm noticing in the crop, maybe I need to test, or in the poultry. So is that awareness there? The other thing that I wanted to highlight was, how do we engage with the private sector? I mean, we've been talking about engaging with the private sector, Dr. Paul, and I very much agree to this, that could be one of the entry points into how we understand, the behavioral drivers of antibiotic resistance in communities. Like, the private sector is completely profit oriented. So how do you engage with them to convince them about what AMR can do, how it can actually, exacerbate the inequities, yes, but also the disease burden overall? And how do you, sort of lobby with them, and how do you make them understand the whole seriousness of the problem? So I think, in a nutshell, Professor Dasgupta, all these things are going to act with each other, in not reducing the inequities, but also, making them even worse in the communities that we are talking about. Thank you.
For your information, the JEDA commitments doesn't actually have the word equity. Though the UN declaration, of course, it has. But quickly onto the JEDA commitment, since it's sort of the talk of the day, just released India's Minister of State for Health, representing the country there in the ministerial conference. One quick question to Dr. Pallavi Mishra, a technicality. I mean, please explain this technicality for audience. The JEDA commitments, though it's an interministerial body, is not considered under the category of non-legally binding instruments. So in international policy terms, what does non-legally binding instruments mean? And then for a problem such as AMR, which involves multiple sectors, how do we really view the JEDA commitments? Dr. Mishra.
Thank you for this question. So it's a non-legally binding, the term, it means that, you cannot hold a country accountable for not, not complying or not adopting any declaration or any international, law per se. But for AMR, for AMR, I would say, I'm sorry, I'm missing the second part of the question. Like, what was this?
The second part of the question really is that, given the urgency of AMR, and if you read it with the tone and tenor of the political declaration of the high level, the UNGA, given that there's this urgency, given that it's very, very intimately intertwined with SDG imperatives and commitments, the fact that these are non-legally binding interministerial commitments, how does one really translate? How does one really move forward in translating this? Do you see that as a challenge?
I see it as a challenge, but I also see that COVID, the recent pandemic as an opportunity. So there was nothing. There was certain regulations that all countries were mandated to adhere to, but there were certain things which came from the local level, from the national priorities, and despite it not being JEDA declaration, not being legally binding, I think it after COVID, I think national priorities in many, not only in developed, but in the developing countries or LMIC setup also has become a priority. So having that in mind, I don't think that, any international commitment or any international declaration not having legal binding will have an impact on, countries setting their priorities, because they are driven mostly by the needs at the local level. And obviously considering the cross-boundary or trans-boundary nature of AMR issues or One Health issues, I think countries will be motivated enough to make it a part of their national policies.
Thank you. So talking of these translations or the translational challenges, there's a question for the veterinary sector. First, Dr. Paul, and then Dr. Ghatak. So, Dr. Paul, now that you see things from the FAO's prioritization and perspective, how complicated is really addressing multiple sectors as far as AMR in veterinary settings go? In other words, how tough is multi-sectoral approach?
It's not the question of toughness. Everyone comes together, but the way we all get in the room, we make commitments and then it goes. So this is what usually happens. If you look at our original UNGA, it has no commitment on the agriculture side. We only say that there'll be 10% reduction of deaths by 2030. There's probably, I'm not so Jeddah, because you said, I was looking at my mobile on the Jeddah declaration. But even in the UNGA, we have probably, Anuj sir can put more light. There has been no commitment on the agriculture side of the problem. Probably all the countries say that data is absent, AMU data is not there. So this is the basic issue. Though we have a WOHA NMUs thing coming, but there is no agreement on the agriculture side of the problem. So we only that 10% that's in the human side. So even at the highest levels, you can understand we have the problem there. FAO as a body, we look at transformational changes in the agri-food systems. So we are committed to see that some of the transformational changes can prevent diseases and bring down AMR. This is what we are looking at from the FAO side. Otherwise, all multi-sectoral engagements, we do agree on many things, but probably it's not followed up with. That's what I want to say to begin with. Maybe Sandeep sir can add something on that.
So, Dr. Ghatak, you are in the Indian Council of Agricultural Research. ICAR itself has multiple sectors within it. So, in the AMR space, what do you face as challenges, and how do you actually negotiate with them?
Well, thank you. As Dr. Rabin, I agree with my colleague Dr. Paul there. Issues that ICAR also as multiple sector, you rightly said. The issues everywhere in our previous work, not only in ICAR, outside ICAR work also, I faced that the sectoral priorities differ among various sectors, and other sectors do not really appreciate it. It has a factor of realization. From the animal science sector, they will never understand what is the problem of AMR in the ICUs. We need more communication. The ICU doctor, like Professor Sagar is there, they will never understand the 100 poultry birds farming farmer, what is the reality livelihood desperation for him. So this difference actually hinders our multi-sectoral collaborations. The people like us who go along, it's fine. We make commitments, but it really does not translate. So we have to intelligently find the levers or the handles where we can work. One handle such that maybe where we can bring this medical problem into the animal side, which is essentially a commercial and economy-driven economic activity. Farming is essentially that. Is that the India has a large network of animal source foods cooperatives, which are managed largely by the group of farmers, but government has substantial control over that. For example, the milk cooperatives and others, they are large. If government can work on those handles, we may ask, the message goes from our booklets, our communication material really does not have very difficult to change the farmers' behavior. But the cooperatives If that channel is imbibed, I think we may have a more potential and stronger lever to change their behavior. As Dr. Rabin went to the fishermen's, there also we are taking such, ICR is taking such effort. One, that the challenges that we are facing, we have, apart from that, Dr. Anuj Sharma, who rightly pointed out that there is constitutional divide made as the state and center, that divide. That is why we have the what that is taken at the union government level decision does not become the same priority for the state government. For example, with Dr. Anuj, we were trying to put the Meghalaya action plan on AMR, but it did not went through because of the political will. Political will is important, and we need more communication material perhaps for the political decision makers than for the farmers. If that comes from that side, no one can stop us in implementing the AMR multi-sectoral collaboration. It just comes. AMR, if you look the players in the AMR, so many players in India, but we are still grappling how to go with it. So many of us are trying to work on. It is, the challenges are so heavy. In ICR inside, we have a formed how we overcame it. We have animal and fisheries separate. We have jointly formed an Infor network, which has now been, which was so nicely, so caringly supported by FAO. Now it has gone into after a couple of years, almost a decade, it has become a network program where the fisheries scientists as well as the animal scientists, they work together so that they report their report in one meeting and all this. So they talk, at least they know each other's problem. So that is the one way, that network, and creating a network. Why did it, has it been successful? Is that ICR sustained, nurtured it. Of course, that was funded by FAO. We are all grateful to them. But that was the commitment we needed almost for 10 years. Without that, it never works. So that has been our experience.
So you make a very important point, and two states, Kerala and Madhya Pradesh. So my questions to Dr. Paul and then Dr. Sagar Khadanga. What these two states have been in some senses first movers as far as the state action plans go. So what were the drivers? Was it is it the technocracy which approached the political leadership, or is it, as Dr. Ghatak seems to suggest, that organizations such as the FAO or the WHO have a strong facilitatory role and the nudge really comes from outside the state? How exactly does it happen? Explain it for audience. Dr. Paul first and then Dr. Sagar.
No, this question, Kerala, Anuj sir is better than me to explain. This thing. If Anuj sir is online, I please answer that question for Kerala. Anuj sir, if you are there.
Kerala actually has moved much ahead than the other states for various reasons. The primary reason is the political will. And as Dr. Ghatak mentioned, the lack of a political will is something which is, critical in moving any agenda forward. Now, if you look at Kerala, the leadership commitment is very strong. The chief minister reviews the AMR. Health minister does it as well, and the bureaucrats do it as well. But one of the critical things is that the advisor to the chief minister prioritizes AMR. As a result, the chief minister prioritizes it. So one of the things to move the agenda forward is to look at these influencers or levers of change who can really make a difference for AMR containment. The political commitment is extremely important. Kerala has a number of firsts, but I think the critical reason is this. Second thing is the bureaucracy in Kerala is very different from a lot of others. They are much more coordinated, and they have actually designated 15 focal points through a government order. Dr. Robin Paul was the focal point for the animal husbandry, and there are currently 14 other focal points. Now there's someone else for animal husbandry, and they have a number of new initiatives. And as a result, one of the key things that we've seen is Kerala is one of the first states to have completely implemented the ban on over-the-counter sale of antibiotics without a prescription, leading to nearly 1,400 crores of savings through reduction in antibiotic sales in just 1 year alone. And this is only one state we are talking about. So I think Kerala has a number of other lessons which the other states can also sort of imbibe, but also Dr. Sagar can share some of the lessons from Madhya Pradesh as well.
Thank you, pardon the pun, for the Kerala story. Dr. Sagar, the Madhya Pradesh story.
In a lighter note, I think Kerala is not in India. It is somewhere in Western nice country. It's very hard to evaluate. If I will take only one point from Kerala, they are doing culture sensitivity at their PSC CSC level. PSC CSCs. I can't imagine at the district level in the state of Madhya Pradesh. MP has 52 districts. Only 2 districts are running some sort of culture. 50 district hospitals do not have culture facility. So whom to blame? Whether the health infrastructure, the bureaucrats, the politicians, I do not know. Probably, again, I will come to my same point. Health is such a market where the consumer do not give its demand. For example, if somebody is in ICU and suffering pneumonia, the patient has got absolutely no choice what to be bought. It is an informed decision by the doctor. Fine. But AMR is such an issue where the consumer should have the absolute right to fight for it. Unless otherwise that is there, I do not think AMR model will be successful outside Kerala at least. So what I did in Madhya Pradesh, like Dr. Anuj told rightly, we tried to motivate few bureaucrats and some politicians. Ultimately, we came in touch with each other. We made some sort of a anti-diagram and moved from there. And what I did in MP, we did extensive training, teaching strategies, working nurses, nursing students, MBBS students, treating doctors. Can you imagine? We take about 4 hours of session of each MBBS graduate who moved into the community. There is some sort of induction program. And the issue of AMR and judicious antibiotic practice, unless otherwise they complete that course, they cannot go and practice in the community. So we started differently because my diagnostic stewardship is poor in my state. So we started with some sort of community engagement, those who are there in the community. The same thing lies with the veterinary. We are slowly moving into, we have figured out the nodals of veterinary in each district. We have trained them. We have made some master trainers, and it is gradually percolating from up to down rather than from down to up in Kerala. I do not think Kerala should be exemplified in any of these AMR workshops. It's impossible to evaluate them. Thank you, Dr. Ravi.
Okay, I'll come to my last 2 questions. We are close to the end of this. I'll ask this to Dr. Pallavi Mishra. You have been part of a study which has been looking. I'm just moving from AMR to a more broad-based One Health understanding. That has been you have done 2 studies. You have been part of 2 studies. One doing a case study of the state action plans of the states that have state action plans, and linked to that, how is the One Health agenda set in the country? So in the AMR context, therefore, what really are the lessons from the One Health agenda setting study?
Thank you for this question, sir. And in terms of One Health agenda setting, the biggest success that we see is the learning from the international experience, whether it is a G20 platform or other platforms. So there is a promotion to cross-learning and learning about best practices which can be implemented in Indian context. And also, as we were talking about the equity issue previously, I think that is also addressed in the One Health framework that is adopted by the Principal Scientific Advisor's Office in the form of One Health Mission. I think earlier the issue was equity was not well addressed. Now, the One Health Mission is, which is in the offing, has provided a platform for different stakeholders and different ministries, departments, agencies to come together and share their concerns, and also to share responsibilities that way. And also, I would say that apart from the health outcomes, there has also been discussion on the non-health outcomes, which is also very important in terms of like production for the veterinary sector, or same is the case with agriculture sector. So apart from human health taking, being a priority, there are non-health outcomes which are also being, being considered. And also, as I mentioned, that there's an opportunity of learning. I think gradually the system is becoming a learning system where the learning is happening, will happen, and we hope that it will happen, and a learning will happen from the community level to the national level, and the information will be shared. And also the earlier efforts, I would say there was missing social science and behavioral science data, and with the commencement of One Health Mission, we hope that gap will also be addressed, and importance will be given to the social science and the behavioral science data, which is very important. So yeah, you are on time.
Sorry, since you mentioned the One Health Mission, just to take forward what you were arguing, what do you think are the priorities for a roadmap that needs to move to make this journey from silos to synergy?
I think I would say interacting with, for the this One Health agenda setting project that we had, and also for the state action plan on AMR, one of the things that we realized is that there is a lack of shared responsibility. There's lack of shared funding. There is lack of shared framework, and also insecurity is not a very, very good term to use, but I think among people who are working on these issues, that is also something to be addressed. And as basic as having authorship on a paper, co-authorship on a paper. So, and when different departments, different ministries are working together, I think giving importance to each according to their contribution, I think that is very important in my opinion.
Thank you. I believe Dr. Sagar Khadanga wants to intervene. You have your hands up.
Yeah,
Briefly,
Rajiv sir started with my quoting of community engagement. None of the panelists are a mass media motivator or a journalist. So what prevented you to bring to them? Why not? I mean, even in elite educated public, we have not thought of the power of the common man, the mass media motivator, journalist, and these lay persons power to intervene on the topic of AMR. I hope I made my point loud.
Thank you. My last question to Dr. Mahua Das. Again, and thanks to Dr. Sagar for actually providing this link. In this era of One Health, where One Health is a rage among all of us in various fields of science and social science, One Health is an absolute rage. But as far as community engagement goes, how do you see the communication, the challenge of communicating what One Health is, whether to a so-called lay person or even to to frontline workers and farmers and so on?
Very interesting question again, sir. Thank you. I think we are talking about AMR, and I think we've discussed enough about the complexity of the problem that we have in hand right now. I think one of the best ways to approach this AMR with a One Health approach and talk about it to the community is, the kind of like Sandeep sir said, that there are these cooperatives that we can engage with to engage with the farmers. So to identify those bodies, at the local village level, for example, or, at whatever contexts that we are working with. So there could be self-help groups, there could be microcredit groups, there could be, ASHA workers, for example. So we have to identify these groups of existing health cadre, or, people who are working in farming, in agriculture, in fisheries, in poultries, who have that outreach at the community level, so that one group can make can meet with the community at various points in time and sort of communicate with them the essence of the message that we are trying to convey around antimicrobial resistance when we are talking about One Health, and the seriousness of its impact on our health. So I think, using these groups, community groups at the local level could be a very good entry point to talk about AMR resistance, antimicrobial resistance, taking a One Health approach. Thank you.
Thank you very much. And as we come to the close of this panel, on behalf of the IPHA, my very sincere thanks and appreciation to all of you. I hand over to Professor Sunila Garg. She is chair of the Indian Academy of Public Health, for your closing comments. And then we'll close this. Professor Garg, please.
Thank you so much, Dr. Rajiv, for moderating such an excellent panel, and I was listening all throughout, and it has been really incidental that yesterday I did a detailed talk on One Health with our, management students and MPS students also, because I feel that, this forms the backbone of when we are addressing antimicrobial resistance. And the theme has been very appropriate for all of you who are listening. That means we are talking about education, advocating, and we are talking of acting now. So we have to follow system strengthening. And one of the important pillars which I could make out is community engagement. An important part is that, when we talk of antimicrobial resistance, we need to, create have an understanding that basically this is a threat to not only human beings, but to animals and environmental practice. So that is where systems come into play. And somewhere, I think we need to talk about vaccination, and we need to talk right now. It's the time to talk about adult vaccination also. So that part becomes very, very important. And then another thing which somewhere came in between was, Swachh Bharat Abhiyan. But also, when we talk about, hand washing and practicing, safe food handling, because international trade and food handlers, these are also important channels which need to be addressed as well. And plus using antibiotics appropriately, which has been throughout the topic of discussion, both, we need to talk not only with regard to our own modern system of medicine, with regard to our private sector, government sector, private providers and all that, but we need to talk to our veterinarians also. And we need to also focus upon, environmental part also. That part becomes very important. And, when somebody mentioned about, Dr. Anuj mentioned about, the HIV part. So I feel that, practicing the education about practicing safe sex and keeping your cuts clean, that part becomes also important. And also, when we talk about chronic conditions, because when we are talking about antimicrobial resistance, so tuberculosis, leprosy and all which was discussed. So this is a carry home message for all our undergraduates and postgraduates that this is an important topic of concern also. So, apart from looking at, that we need to prescribe antibiotics carefully and educating people about antibiotics as well, But, over-the-counter availability of antibiotics, this needs to be regulated. So that part becomes very, very important. We do have, now, fourth guideline on antimicrobial resistance, which is focusing on, lactamase-producing organisms and carbamazine-resistant organisms. So this part, and also we have Delhi strain as well, which is resistant to, all the antimicrobes. So that part, we need to regularly do that. And plus, we need to monitor the microorganisms with regard to veterinary sciences and what are the circulating organisms within the environment. So I feel that each of the institution, whether we talk of East, West, North, South, they need to have their own tailor-made within the broad guidelines of hospital-acquired infection framework. We need to have our specific guidelines also, because what fits to North may not definitely fit, at the micro level with South or East and West. And another thing which I was hearing is that all throughout it is political will, which is very important. And I think DGCA has got a very, very important role to play in this whole thing. So when we talk about, disinfection, sterilizing medical devices and all, this has to become a part of our own system. So with this, I feel that it has been a very, very important topic of discussion. And most of the things have been discussed. And Dr. Rajiv, you really touched every corner of this part, and I feel that this was the topic of discussion for this week. And I feel that all our undergraduates and postgraduates are going to benefit by this. But one health is the need of the hour. When we focus on all, animal health, environmental health, and at the center is the human health. So thank you so much. And thank you all the lovely panelists. It has been really exciting listening to you. So all the very best and have a good, safe evening. So thank you so much. And thank you, IPHA, for organizing this. My colleague, Dr. Sanghmitra, and our, Secretary General, Dr. Kaushik, and, all the organizers, it's been really great. Thank you so much. Thank you.
Thank you very much. And once again, on behalf of the Indian Public Health Association, we are an 11,000 plus strong membership. All our webinars are available on the YouTube channel. So to the organizing team and to the IPHA leadership, thank you very much. We'll close this. An absolute pleasure. Thank you very much and good night.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye-bye.